Physostigmine, Aricin. It is an alkaloid obtained from Physostigma venosum. It is a tertiary amine and has good penetration through tissues. Its actions are similar to those of other cholinergic agents. Uses: glaucoma. Physostigmine reduces intraocular pressure by producing miosis, thus facilitate the drainage of aqueous humor. On chronic use, it accelerates cataract formation, hence it is rarely used in glaucoma. Atropine poisoning. Intravenous physostigmine is used for severe atropine and other antimuscarinic drug poisoning because it has both central and peripheral action. It competitively reverses the effect of atropine poisoning, but it should be used cautiously by slow IV injection as it may cause bradycardia. Neostigmine. It is a synthetic anticholinesterase agent. Its actions are produced on gastrointestinal tract and urinary bladder, then on cardiovascular system or eye. On skeletal muscle, it has both direct and indirect action. Indirect actions: by inhibiting cholinesterase, neostigmine increases acetylcholine concentration at neuromuscular junction. Direct action: because of structural similarity with the acetylcholine, that is quaternary ammonium compound, neostigmine also directly stimulate NM receptor at NM. Thus, it improves muscle power in patients with myasthenia gravis. Neostigmine does not cross blood-brain barrier and has no central side effect. Therefore, neostigmine is preferred over physostigmine in myasthenia gravis. It is available for oral, subcutaneous, intravenous, and intramuscular administration. Pyridostigmine. All features are same as neostigmine. Pyridostigmine has a longer duration of action and can be given twice daily in sustainable release form. Hence, it is preferred over neostigmine in myasthenia gravis. Even though the pyridostigmine is less potent than neostigmine, it is better tolerated by myasthenic patients. Adrophonium. It is a quaternary ammonium compound. On IV administration, it has a rapid onset but short duration of action, 8 to 10 minutes. Uses: Adrophonium is used in diagnosis of myasthenia gravis. It is also used to differentiate myasthenic crisis from cholinergic crisis. In curare poisoning, adrophonium is preferred because of its rapid onset of action. Adverse effect of anticholinesterases. They are due to overestimation of both muscarinic and nicotinic receptor. Increased sweating, salivation, nausea, vomiting, abdominal cramps, bradycardia, diarrhea, tremor, and hypotension. Therapeutic uses of reversible anticholinesterases. In eyes, for glaucoma, to reverse pupillary dilation after refraction testing. Myotics are used alternatively with mydriatics to break adhesion between iris and lens. To treat myasthenia gravis, in postoperative urinary retention and paralytic ileus, in curare poisoning and reversal of non-depolarizing neuromuscular blockage, in belladonna poisoning, and in Alzheimer's disease. Glaucoma. The aqueous humor formed by ciliary process is drained mainly through trabecular meshwork. Glaucoma is a progressive optic neuropathy which leads to damage of optic nerve with loss of visual function that is frequently associated with raised IOP. Normal IOP varies between 10 to 20 mm of edgy. Management of this disorder is almost always directed at lowering the existing IOP either by improving their drainage or decreasing the formation of aqueous humor. Acute congestive glaucoma. It is usually precipitated by mydriatics in patients with narrow iridocorneal angle and shallow anterior chamber. Acute congestive glaucoma is a medical emergency. Once the attack is controlled, treatment is surgical or laser iridectomy. Chronic simple glaucoma. It is a genetically predisposed condition affecting the patency of trabecular meshwork. The IOP rises gradually. Pharmacotherapy is the definitive treatment in majority of cases. Drug used in glaucoma. Osmotic agents. Mannitol 20% IV infusion, 1.5 gram per kg body weight, and 50% glycerol oral, 1.5 gram per kg are used. They draw fluid from the eye into the circulation by osmotic effect and reduce IOP in acute congestive glaucoma. Carbonic anhydrase inhibitors, acetazolamide oral IV, dorzolamide topical, and brinzolamide topical are carbonic anhydrase inhibitor. They inhibit carbonic anhydrase enzyme and lower IOP by decreasing the formation of aqueous humor. Topical carbonic anhydrase inhibitors, which have a much lower risk of systemic side effect, are preferred over the systemic carbonic anhydrase inhibitor in chronic simple glaucoma. In acute congestive glaucoma, acetazolamide is administered IV and orally. Beta blockers. Topical non-selective beta blocker are timolol, bitaxolol, levobunolol, carteolol, and metipranolol. Timolol is widely used in glaucoma because it lacks local anesthetic or partial agonist property. It does not affect pupil size or accommodation. It has a longer duration of action. It is well tolerated. It is less expensive. Topical timolol is safer and highly effective. Petaxolol is selective beta 1 blocker used in glaucoma, but it is less effective than non-selective agent. Betaxolol is protective to retinal neuron. Levobunolol is long-acting. Beta blocker should be cautiously used in patients with a bronchial asthma and heart failure. Prostaglandin PGs. Topical PGs such as latanoprost, travoprost, and bimatoprost PGF2 alpha analog are preferred agent for initial therapy in open-angle glaucoma because of their longer duration of action, high efficiency, and low incidence of systemic toxicity. They are also used in acute congestive glaucoma. They reduce IOP probably by facilitating uveosacral outflow. Latanoprost is also available in combination with timolol. They are usually do not cause systemic side effect but may cause ocular irritation and iris pigmentation. Meiotic. Pilocarpine is a tertiary amine and is well absorbed through cornea. It is used topically in treatment of open angle and acute congestive glaucoma. It facilitates drainage of aqueous humor and reduce IOP. Alpha-adrenergic agonist. Apraclonidine is used topically as an adjuvant in glaucoma. It does not cross the blood-brain barrier, hence it has no hypotensive effect like clonidine. Apraclonidine and brimonidine are alpha-2 agonists which reduces the formation of aqueous humor and then decreases the IOP. Another drug, dipivefrin, which is a prodrug of adrenaline, it penetrates the cornea and with the help of esterases, it gets converted into adrenaline. Myasthenia gravis. Myasthenia gravis is an autoimmune disorder where antibodies are produced against the NM receptor of NMJ, resulting in a decrease in the number of NM receptor. There is an increased incidence of myasthenia gravis in patients with thymoma. Thymomectomy can induce remission in most cases. In myasthenia, there is a marked muscular weakness varying in degree at different times. Myasthenia gravis is diagnosed by typical signs and symptoms, weakness and easy fatigability, adrophonium test. Adrophonium 2 to 10 mg given slow IV showed dramatic improvement of symptoms in patients with myasthenia gravis, but not in other muscular dystrophy. Demonstration of circulating antibody of NM receptor. Treatment. Anticholinesterases, neostigmine, pyridostigmine, and abinoam are effective in providing symptomatic relief. They inhibit metabolism of acetylcholine, thus prolonging its action at receptors. Neostigmine also directly activate the NM receptors. Physostigmine is commonly used. Long-term use or overdose of anticholinesterases lead to cholinergic crisis. severe muscular weakness, and neuromuscular paralysis due to prolonged depolarization. This may be differentiated from myasthenic crisis, severe weakness due to exacerbation of myasthenia. By injecting a small dose of edrifonium 2 mg IV, if patient shows improvement in muscle power, it is myasthenic crisis. If the muscular weakness deteriorates, it's cholinergic crisis. Ventilators should be kept ready before injecting edrofonium as it may aggravate cholinergic crisis, which is dangerous. Corticosteroid and other immunosuppressant like azathioprine or cyclophosphamide are useful in the induction and maintenance of remission. Plasmapheresis and immune therapy may be useful in resistant cases. Note: drugs that aggravate myasthenia, that is, drugs that are contraindicated in myasthenia gravis, are aminoglycoside, antibiotics, deep tuberculosis, and other neuromuscular blocker, beta blocker, ether, phenytoin, etc. Post-operative urinary retention and paralytic ileus. Neostigmine is used because it increases the tone of smooth muscle and relaxes the sphincters. Curare poisoning and reversal of non-depolarizing neuromuscular blockage. Adrofonium or neostigmine is used. They antagonize neuromuscular blockage by increasing the concentration of acetylcholine at the NMJ. Prior administration of atropine is a must to block the muscarinic side effect. Belladonna poisoning. Physostigmine is preferred because it reverses both central and peripheral effect of atropine poisoning. Alzheimer's disease. It is a degenerative disease of cerebral cortex. Donepezil, galantamine, and rivastigmine are cerebroselective anticholinesterases. They increase cerebral level of acetylcholine and have shown to produce some benefit in this patient. Reversible anticholinesterases. Organophosphorus insecticides. All organophosphorus OP compound except ecothiophate have non-therapeutic application. Ecothiophate is rarely used in resistant cases of glaucoma. Organophosphorus compound have only toxicological importance. Organophosphorus poisoning is one of the most common poisoning all over the world. Common organophosphorus compounds are parathion, malathion, diflos, etc. They irreversibly inhibit cholinesterases and cause accumulation of acetylcholine at muscarinic and nicotinic site. Sign and symptoms: muscarinic effect, profuse sweating, salivation, lacrimation, increased tracheobronchial secretion, bronchospasm, vomiting, abdominal cramps, meiosis, bradycardia, hypotension, involuntary urination and defecation. Nicotinic effect, twitching, fasciculation, muscle weakness and paralysis is due to prolonged depolarization. Central effect, headache, restlessness, confusion, convulsion, coma, and death are usually due to respiratory failure. Diagnosis: organophosphorus poisoning can be diagnosed by history of exposure, characteristic sign and symptom, estimate the cholinesterase activity in blood which is decreased, treatment, general measures, remove the contaminated clothes, wash skin with soap and water. Gastric lavage should be continued till the returning fluid is clear. Airway should be maintained. Artificial respiration is given if necessary. Diazepam should be used cautiously by slow IV injection to control convulsion. Specific measure: atropine. Atropine is the first drug to be given in organophosphorus poisoning. Inject atropine 2 mg IV stat and it should be repeated every 5 to 10 minutes, doubling the dose if required till the patient is fully atropinized, fully dilated, non-reactive pupil, tachycardia, etc. Atropine should be continued for 7 to 10 days. Atropine competitively blocks the muscarinic effect of OP compounds, competitive antagonism. Oxim. Atropine is not effective for reversal of neuromuscular paralysis, Neuromuscular transmission can be improved by giving cholinesterase reactivators such as pralidoxim, obidoxim, etc. Pralidoxim is administered intravenously slowly in a dose of 1 to 2 gram. OP compound inactivate cholinesterases by dephosphorylating esteratic site of enzyme. Oxim bind with the high affinity to anionic dephosphorylate the enzyme and reactivate it. Early administration of oxime is necessary before the phosphorylated enzyme goes aging, loses alkyl group, and become resistant to reactivation. Oxime are non-effective in carbamide poisoning. They also have mild anti-CHE activity, delayed toxicity of organophosphate. Prolonged exposure to organophosphorus compound can cause neurotoxicity.